Okay, hello. This is a strange experience for a start, being in a room talking to myself by myself. But I'm glad to be invited to the Nursing in Practice 2020 conference with this kind of on-demand session around borderline personality disorder. So you can see I've titled it A Critical Introduction to Borderline Personality Disorder. So keep open minds and try and think critically throughout. So who am I? I'm a lecturer in mental health nursing at Robert Gordon University. I'm also a PhD student studying the experiences of crisis intervention for people diagnosed with borderline personality disorder. I still do a bit of clinical work as a mentalization-based therapist, work primarily with people with that diagnosis. And I'm also part of the executive group for the Scottish Personality Disorder Network. So that's a little bit about me. Now, this is a really complex topic, and it is a brief introduction. It's probably going to be about kind of 40 minutes-ish. So with a lot of concepts that I'm introducing, we are really only kind of scratching the surface. So I'll introduce a lot of ideas, and please, follow them up in your own time and try and learn more about them. I really miss the connection with an audience. I think that's maybe something that's happened to us all in 2020, which has been a bit of a kind of bizarre year. So my email address is there, and I'll put it up at the end. Feel free to get in touch through there or through Twitter. Because it's all on demand, you'll be watching a recording of this. I might encourage you to sort of pause at some points to read the slides, so I don't have to kind of read them through to you. And just, I guess, a trigger warning that we will be discussing trauma and maybe some traumatic experiences. So keep that in mind and keep yourself safe if you are kind of watching this. Okay, so let's rattle through some of this stuff then. Okay. So the aims are really that we look at the experiences and symptoms associated with BPD, diagnosis or diagnosis. So we'll think about some of the critical debate around the diagnosis and think about how healthcare helps and how it harms. So that's the sort of main aims that we'll try and rattle through today. Now, first a note regarding language. So you'll notice that I've put BPD in inverted commas. And that's a deliberate thing to highlight the kind of controversy and the debate around the diagnosis. Not that arguing that the distress isn't very real, because it absolutely is, but the way that we understand that is absolutely up for debate. And so really got the inverted commas there to emphasize people's kind of ability to understand their own experiences in their own way. Try and think about people diagnosed with BPD rather than people with BPD, because there is a lot of debate around kind of labeling people as disordered. Okay, so that's a bit of a background to that. So first we'll do some experiences and symptoms associated with BPD. So thinking about some of the kind of causes of why people might have difficulties, and then what might those difficulties be. Okay. So the etiology is a biopsychosocial model, okay? So a combination of genetic, biological, psychosocial, and environmental factors, okay? So there's no one thing that is known to sort of lead to BPD diagnosis or BPD symptoms. It can be a variety of things. What I will be emphasizing throughout this is that the things that happen to people are the most powerful explanation. A quick word about genetics, because you'll see genetics are in there. There is no BPD gene, okay? There is no sort of one BPD gene that people pass on and therefore you will have BPD. Genetics does have a role in all of us, but there's certainly not a kind of BPD gene. So the genetics are supposed to be a kind of genetic plasticity where we adapt to our environments. Our behavior, our thoughts, feelings are activated by experiences that we have, and they might kind of push us towards sort of seeing the world in a certain way or behaving towards it in a certain way. So even if we are understanding it as a kind of genetic influence, that genetic influence is activated by experience. Okay, so there's no BPD gene. It's really important that you remember that. Adverse childhood experiences, trauma, difficulties in attachment relationships. We'll certainly talk about attachment and trauma. And I'm sure everyone should be aware of kind of adverse childhood experiences. There's a big sort of push in public health campaigns around that just now. And that's very important when we're understanding the diagnosis of BPD as well. And always remember that people have got an absolutely unique path to the development of difficulties, okay? I mean, For some people, it might be one really traumatic event, might be a traumatic childhood. For many people, I think you can think of anyone with mental health issues as a sort of spider's web of things that kind of come together. And as a result of that, they end up in the middle and end up having difficulties. So some of the epidemiology, the prevalence in general population of Western countries, 0.7% to 5.9%. 0.7% I think was Norway, 5.9% was the USA. UK sitting at kind of 1 to 2%. But I think we need to kind of take figures like this with a pinch of salt, given difficulties kind of making the diagnosis. That's a very sort of rough estimate. Now, 70% diagnosed are female. That's going to be really important when we talk about trauma and some of the kind of sociological stuff later on. There are some some people have proposed that maybe men are underdiagnosed, or men might be diagnosed with antisocial personality disorder, might externalize their distress into kind of violence, maybe more than women do. Or men might be in jail or engaged in substance use services as well. Okay, but certainly the majority of people that end up getting this diagnosis are female, and that's an important thing to consider. Why might that be when we're thinking critically later on? And certainly a high use of healthcare services as well, predominantly when people are in crisis, which is obviously the reason that I've kind of become interested in this topic. So attachment. So attachment theory, very important to understand. So the kind of mother and father of attachment theory, John Bowlby and Mary Ainsworth, so certainly kind of worth looking at some of their work. So the idea behind attachment theory is that infants are predisposed to attach to caregivers for survival and to regulate internal emotional states. So it's something that we're kind of born with, you know what I mean? We're born going into the world, seeking out that attachment. Not only because it helps us survive, but it helps us kind of regulate ourselves, and it helps us kind of learn about ourselves and learn about the world that we're in as well. Attachment behavior is adaptive, okay? So we learn to do what works to have our needs met, okay? So depending on what environment you grow up in, you will develop different strategies, and these can be different strategies with different people for getting your needs met, yeah? And what we can do is we can take these strategies into later life, because your early relationships create a template for later ones. So you get a sense of, right, this is how life works, this is how people work. In these relationships, I need to do this to get my needs met, therefore in future relationships, I'll need to do that. But that's very kind of, that can change over time. There's no one strategy that people will use kind of with all people. You might have one strategy for your dad, one strategy for your mum. You do what works, okay, and that can be different for everyone. I guess just looking at the pictures that I've got here, this is that's me and my kids. So that's my kind of daughter at the top, and my face there as well. Now the idea behind that is that what we need for secure attachments is a marked mirroring of mental states. So you see my daughter looking sad there, and I'm just kind of reflecting back to her. She's really sad, and I'm not directly mirroring, I'm not being sad back, but I'm just going, oh, you know what I mean? Just that, and that's, sorry, that looked really patronizing there, that, oh, but it's much easier to do with a kind of genuine human being, and I'm talking to a camera in my room. But what I'm doing is reflecting back to her my understanding of her mental state. And as a result of that, she will get an understanding of herself, understanding of other people, and an understanding of where she fits in all of that as well. For a good example of that, just Google the still face experiment, which is a really important experiment that will give you a sense of how human relationships develop and how they're so important for our mental health. Now, I really like this quote from Bateman and Fornicke. So our understanding of others critically depends on whether, as infants, our own mental states were adequately understood by caring, attentive, non-threatening adults. Now, personality disorders are associated with difficulties in understanding other people in relationships. And we need to keep in mind, how difficult is it going to be to understand others if you yourself have not been understood? So really important we keep that in mind. So what secure attachments do is or insecure attachments for that matter, they help us develop an internal working model. So essentially a way of kind of seeing the world. And again, like I said, beliefs about the self, beliefs about others, and beliefs about the relationship between yourself and others as well. And if you really think about this as a way of seeing the world, then imagine that your experiences are such that you go into the world and you trust people. You've got a genuine kind of sense that people are going to care about you, respect you, value your opinion, those kind of things. Then think about you have a really, really difficult experience. And imagine it just sort of kind of putting on a set of glasses where suddenly the world looks really, really different. The world can look incredibly scary. You can be worried about how people are going to respect you, value you. You can think that you're worthless. So, and if you have a different lens, a different way of looking at the world, you're going to react to it differently. You're going to behave differently because that is a different world for you. So that's one of the first things to remember, is that we all see the world differently. And if people have had traumatic kind of environments when they've grown up, or not necessarily directly traumatic, but neglectful, we've not been understood, then that's going to have an impact. And you can think about that as sort of learning about yourself from the outside in. Like, how much would you truly know about yourself if you were the only person on the planet Earth? You need a bit of that kind of psychofeedback so you get a sense of who you are. Always keen when we talk about attachment not to kind of get into parent blaming. You know, I mean, I think it's a really difficult thing if people have got symptoms of BPD, have that diagnosis, often really difficult for the parents as well. And there might be a bit of kind of self-blame there. Sometimes it is absolutely down to kind of that relationship with parents. But your internal working model can be shaped by a variety of things, even something like kind of bullying at school. You know, I mean, that in itself can shape your sense of self, the way you see yourself and others. So there's a variety of things that can lead to difficulties. And next up, we're going to kind of talk about trauma, which is really important as well. So there's high correlation between childhood sexual abuse and BPD. And in a study from last year, BPD, people diagnosed with BPD, 13 times more likely to report adverse childhood experiences than non-clinical control groups. Okay, and I mean, having worked with people with the diagnosis for a number of years now, it's rare, but well, I can't think of any time where I've worked with someone where there hasn't been some kind of failed attachments or trauma in their background, and things often make sense when you take those things into account. So what trauma does is it impacts on the body and brain. Now, for more detailed kind of explorations of that, you might consider Bessel van der Kolk's book, The Body Keeps the Score, which is worth looking at, or Judith Herman, Trauma and Recovery. But very quickly, just to kind of talk through this, we've got the brain there. So the reptilian brain, which is our kind of most primitive brain, the mammalian, and then the kind of the neocortex, the top, which is the human brain, what makes us human. Now, the reptile brain, what it does is kind of notices. So you're looking about for danger, you know what I mean, what's going on, try to check out the environment. The mammalian brain, in the middle, the limbic system, will kind of process that information, okay? Your amygdala sits in there, so that can be your kind of smoke alarm. Is there danger? Is there danger? What's going on? And then what happens is your human brain at the top, that'll rationalize, yeah? Okay, so I'll see something out my window, I'm noticing it, thinking that's a threat, and then my human brain will just go, oh, it's just a postie, okay? So that rationalization helps you kind of navigate the social world. Now, what can happen is if you have experienced trauma, is that the wiring in your brain actually becomes heightened to seek threat. So your reptilian brain has a heightened threat perception. So that noticing is hyperactive, yeah, and it makes perfect sense because you don't want to be hurt again. So you're going to be extra vigilant. There's going to be an attentional bias, and that will depend on the trauma that person's experienced. And that's really important when you're thinking about people's individual triggers. They are so unique to the individual. A trigger can be a smell, a color. It might be a sex of human being. You know what I mean? Is it men that are triggering? That'll depend on what the trauma was for the person. So the heightened threat perception and the intentional bias as well. What happens in the limbic system is that the amygdala becomes overactive. So that smoke alarm goes, that's loud, yeah? That's really, really loud. And it becomes fear driven as well. And again, these are adaptive things because you don't want to be hurt again. And as a result of the overactivity of the amygdala in the limbic system, your human brain actually becomes less active. So that bit where you can sort of rationalize and say, it's just the postie, that's actually impaired. And what they call that is fear extinction. So knowing when something's not a threat or knowing when a threat has passed. So hopefully that's just a really, really quick overview of what can happen in the brain. But when it doesn't necessarily make sense to us, why is this person reacting in this way? We might need to try and think, right, I wonder what's been their previous experiences that have led to kind of interpreting the world in this way. I wonder what's going on for them. So you've got that kind of hard wiring to the body and brain, but then in the same way as attachment, trauma will shape a person's worldview in interpersonal relationships, and then it makes perfect sense that they would find it difficult to develop trusting relationships with others. And it's important for us to remember as healthcare practitioners, healthcare professionals, that they could also find it difficult to trust us, and it might make perfect sense. No matter how remarkable or amazing or caring we think we are, people might be hardwired or have had experiences which have led them to view the world in a certain way, which make perfect sense. Okay. Now, these are the diagnostic criteria for BPD. You can just take a moment and pause and look at them if you want to. I don't want to kind of look at them in detail because we're going to sort of talk specifically about, I think, some issues that tie this diagnostic criteria together. But certainly, difficulties in relationships is a common feature, and probably the thing that gives us most anxiety as professionals is the recurrent suicidal behaviour, gestures, threats, or self-mutilating behaviour. Okay, so that's that diagnostic criteria there. But then take a moment and pause this as well and have a look at the core difficulties resulting from trauma. So you'll see that there are a lot of similarities here, and that's certainly will come into some of the debate about the diagnosis later on. Now, symptoms and experiences. So onset of symptoms with BPD is normally supposed to be by kind of early adolescence. Can be called late onset with over age 25. But again, I think we can look at any age. If you experience difficult circumstances, you might experience a certain way of looking at the world which might cause you difficulties. It's helpful to think of symptoms as things that people feel and things that they do. I think, like, I'm not gonna sort of hide from the fact that I will be pushing you away from a kind of medical model of looking at these issues and thinking about them in terms of people's lived experience rather than having a disorder or having an illness. There's general agreement in the symptoms of severe emotional dysregulation, so just being absolutely overwhelmed by emotions, not necessarily able to understand or control those states. A strong impulsivity, so not necessarily thinking through kind of actions or consequences, can be a rush to kind of doing things. And that social interpersonal dysfunction, so that difficulty in relationships, which we've sort of already discussed, can be very understandable for people. And you can think about those issues as like a claustrophobia in your own skin. You know, I mean, people have described kind of just wanting to feel like they can tear themselves out of their own skin, feeling like a pressure cooker, feeling like a kind of fizzed up cola bottle, just that real discomfort inside your own kind of experience, which people are just trying to manage. People can have repeated crisis, and that's a multidimensional subjective experience. I think we'll often see things like self-harm and suicidality, but there's much more to it than that, and we often focus on the behaviour rather than the whole experience. And suicide completion rates range between 3.8% and 10%, and that's obviously a reason that gives us all enormous kind of cause for worry, because we want to help people and we don't want people to die. Yeah, okay. Okay, genuinely hope this is still interesting for human beings, so I'm going to have a drink of water. I think you would have managed to figure that out on your own. Mentalization. Okay, now, really important concept when you're understanding the difficulties associated with BPD. So mentalizing, it sounds like a really fancy term, really clever. It's actually a really subtle social process that we all do. So mentalization is looking beyond behavior, understanding self and others in terms of mental states. So imagine I start crying right now and just kind of throw down my earphones and kind of go away, and you're just kind of left with this empty space. Now, probably the first thing you're going to do is just wonder, just have that sort of confused face and be like, wonder what that's about. That is mentalizing. That is wondering what's going on. Yeah, wonder what's going on in that mental state that's contributed to that behavior. So looking beyond the behavior, understanding self and others in terms of mental state, and the self and others is really important. So conceptually, in between mindfulness and empathy, because it relates to self and others. So empathy, normally something that's directed at other people. I wonder what's going on for them. But when we're mentalizing, we need to figure out what's going on for ourselves as well. And I think we've probably all had moments where you feel maybe like a kind of a passenger in your own skin. You think kind of, why did I do that? What was I thinking? So you need to do a bit of mentalizing of yourself, you know what I mean? And to do that, you just say, right, what am I thinking? What am I feeling? Where is that coming from? How can I make sense of that? And if you're doing it with other people, it's exactly the same. I wonder what they're thinking. I wonder what they're feeling. I wonder what that might be about. Okay? And you can think about that as seeing others from the inside and seeing yourself from the outside. Now, overall capacity to mentalize will vary between individuals, but it fluctuates for everyone. And while I will talk about maybe some of the difficulties in people diagnosed with BPD, mentalizing, it's really important to remember that you can have difficulties mentalizing too, okay? Sometimes you're not looking beyond behavior. Sometimes we are very behavior focused. If you've ever heard BPD associated with the term just behavior, then you're not mentalizing, okay? And that is a pet hate, and I will mention that again. So remember that you don't necessarily always mentalize as well. So difficulties mentalizing are proposed as a core feature of BPD. And we've talked about attachment relationships, building up that understanding of self and others. So that ties into there. And we've talked about trauma impacting on the activity of the prefrontal cortex and the human brain. So that would make sense why mentalizing would be difficult for people. Now, non-mentalizing is often assuming others' mental states. So just to give you a really brief example, so this little cartoon here is from a kind of a YouTube video around MBT. Now, what's happened in this kind of scenario is that this couple are on a date, and the guy's just yawned, okay? And she's thinking, go to hell, I never liked you anyway, okay? So she's taken something, a subtle kind of social cue, a yawn, and thinking, you are not interested in me, you don't want to be here with me, you don't like me. And then her reaction is to think, well, go to hell, I never liked you anyway. And I think we can probably all identify with moments where we've sort of jumped to conclusions, you know what I mean? We've thought, oh, they just don't like me, or, you know what I mean? A variety of things where we're not looking too hard beyond the surface. So we can all do this, yeah? So we can assume others' mental states. And what good mentalizing does is it takes assumptions and turns them into inferences, yeah? So we try and figure out, we look to the gray areas, yeah, and we try and figure out, I wonder what's going on there. If mentalizing is wondering, then non-mentalizing is having an absolute certainty around what other people are feeling and thinking. So good mentalizing can be when we come to understand our misunderstandings with others. So if this couple get to a point where they can realize that, oh, right, okay, yawned and I felt like you weren't interested in me, but I can understand now that you're telling me that you were just tired. Yeah. And hopefully you can all do a bit of thinking and recognize times in your life where you've not necessarily mentalized well, and that has led to difficulties. So good mentalizing, it's understanding misunderstanding. And what we have to get if we are working with people diagnosed with BPD is that sometimes they won't necessarily get it. They won't have an idea of our mental state. They might have assumed something. And that's why we can try and be really clear about what we're thinking and feeling, make our own mental states transparent. Okay. So hopefully you're still with me. Diagnosis or diagnosis. Now, if I'm trying to mentalize here, I'm trying to see myself from the outside. I'm wondering what people are going to think when I'm saying diagnosis or diagnosis. Is he saying that kind of BPD isn't a valid thing? Is it not real? What I'm going to say is that the symptoms or experiences associated with BPD, the distress is absolutely real for everyone. It's legitimate and we should help people with that distress. But the way that we understand that distress is absolutely up for debate. Okay. So just some quick definitions of personality disorder associated with ways of thinking and feeling about oneself and others that significantly and adversely affect how individual functions in many aspects of life. So already you can see that kind of echo from what we're talking about with mentalizing. It's a sort of relational issue a lot of the time. Difficulties understanding yourself, difficulties understanding other people. And a recurring condition that when present hinders mutual understanding. Okay, so difficulties understanding yourself and understanding others will have an impact on relationships. So in terms of the diagnosis, always worth saying to people, because there's still a myth around, because it's called borderline personality disorder, people think that it is almost a personality disorder. Now the term borderline comes from a guy, Adolf Stern, in 1938, said that it was a group of patients that he said weren't quite just neurosis, like your anxiety, depression kind of stuff, and weren't quite psychosis, your kind of, I guess, associated with symptoms of schizophrenia, etc. So he said a group of people bordered on those two conditions. So that's where the term comes from. I don't think the term's helpful in any way in terms of actually understanding what's going on for people, but the term has stuck. So I would kind of remove any sense of the borderline actually meaning anything, because I don't think it really does at all. Now, there are two categories of diagnostic criteria. So the DSM, the American Diagnostic Statistical Manual of Mental Disorders, and the ICD-11, which we use in Europe and certainly in the UK. Borderline personality disorder in the DSM-5, and ICD-10, which was 1992, had emotionally unstable personality disorder, borderline type. Both exactly the same diagnoses. Emotionally unstable personality disorder, I will say, is probably more descriptively accurate in terms of the difficulties that people experience, although we can certainly argue about the personality disorder bit there. The DSM-5 had categories of personality disorder. So there's paranoid, schizotypal, schizoid, antisocial, histrionic, narcissistic, avoidant, dependent, obsessive, compulsive, and borderline. Now what the ICD-11, so new diagnostic criteria that's kind of coming out and being trialed in a minute, has a spectrum of personality disorders. So moving from personality difficulties to mild, moderate, and severe disorder. I'll talk about some of the difficulties in the kind of categories just in a second with comorbidities, but it was felt that actually the categories of personality disorder may be not useful, and maybe the best thing is to kind of figure out if somebody actually has symptoms or experiences associated with a personality disorder before we kind of try and categorize it. But there was obviously a lot of apprehension around that. Borderline personality disorder is the diagnosis with the most research and evidence-based treatment attached to it. So just to kind of pull the rug underneath kind of people's feet in terms of the work that they're doing around that was felt to be kind of maybe sort of damaging in a lot of ways. So what's happened is that borderline type remains as a descriptive qualifier. So somebody might have moderate personality disorder, borderline type. And the reason I'm kind of going through this is just so you know that looked like there was a potential that there might not be BPD in the new kind of criteria, but there's been a decision that that will kind of remain, certainly for the time being. So we're not getting rid of kind of BPD at the minute. So that's a sense of kind of the diagnostic stuff. Now, to critique diagnosis, and you can critique any psychiatric diagnosis in this way, there's no objective test for psychiatric diagnoses, in the same way as like physical health has blood tests, objective, measurable things. Mental health is often diagnosed through subjective judgments, through a psychiatrist or mental health professional that looks at a set of kind of behaviors, categorizes these into symptoms, maps these symptoms into disorders and says, right, you've got this thing, okay? But there's no objective test for it, and as a result, there's been a lot of kind of critique of psychiatric diagnosis. In terms of the science of it, so if you look at the earlier slide, there was 9 symptoms of BPD. What the DSM criteria says is you need 5 or more of the 9, but there's no core features, okay? So you don't definitely need 1, 2, 3, and then the rest are kind of, you can have whatever of them. You have any 5 of that 9. So what that means is you could have symptoms 1, 2, 3, 4, 5, or you could have 9, 8, 7, 6, 5, you could have 2, 4, 6, 8, 9, you could have all 9. And there's been an algorithm done in terms of the number of possible combinations of the disorder, and they say 256 possible distinct presentations. So 256 different people, all with slightly different presentations, all with the same diagnosis. And again, it's a moment for thinking, right, okay, how useful is that then? There's a high prevalence comorbidities. So an individual with pure BPD is rare. So it's unlikely that somebody will just have BPD. They'll often have a variety of other kind of diagnoses, and BPD is comorbid with like almost everything. You know what I mean? Anxiety, depression, eating disorders. There's a huge list of things that they're kind of comorbid with. There's an overlap with autistic spectrum disorder conditions. I think probably largely you could think about that as the kind of due to the difficulties in mentalizing. Maybe that's led to that kind of difficulty there. And shared characteristics with complex post-traumatic stress disorder. And you saw earlier, kind of compared difficulties of trauma with the diagnostic criteria, and I think it's easy to see why that would be the case. So what you get is a potential for a highly heterogeneous group of patients. So hugely different people, and they've all got the same label. So we have to think about how valuable that is. Okay. So is it diagnosis rather than a diagnosis? Now there's some really powerful sociological kind of arguments around psychiatric diagnosis. So the diagnosis is not clinical pathology, but represents a cultural disapproval of behavior. So the idea that these are social judgments, okay? So BPD is not an illness necessarily, but it's a cultural kind of disapproval of behavior. We don't like people behaving in this way, therefore we're going to kind of diagnose it as deviant. Okay, and you certainly require critical thinking to really think about that in terms of a kind of sociological context, the world in which we live, what's acceptable behavior and what is not. Thinking about female behavior in particular, so I was saying earlier that the diagnosis is 70% female in terms of the people that are diagnosed. So is this the same as when women were diagnosed as deviant or difficult historically and viewed as kind of witches or hysterical? And I think that's an argument we really need to think about. And there's a book by Jessica Taylor, people might have heard of, Why Women Are Blamed for Everything. It's certainly worth looking at in terms of kind of expanding your understanding of that argument. Symptoms can be reframed as understandable responses. I think I've really been making that point as we go through, because I think it's really important to keep that in mind. So diagnosis can be invalidating, and what it can do is frame what people feel and do into something they have or something they are. And I use that quote when I'm teaching all the time because I think that's really important, because we take people's feelings and people's actions and we categorize them and we put them into boxes and say, as a result of you being traumatized or kind of neglected, you have this thing. And I don't think that's necessarily the best way of thinking about it. So if behavior is understandable, then is it unjust to label people disordered? And I'm certainly kind of arguing that I think it might be. And there are actually movements for BPD to be abolished, embraced by professionals and people with a diagnosis. So think about a disorder for everyone and personality disorder in the bin. And a couple of the resources I've got there, so that's a disorder for everyone. They hold events that are certainly worth attending in terms of challenging the culture of psychiatric diagnosis. But the power threat meaning framework is a really interesting alternative to psychiatric diagnosis, certainly in its early stages in terms of how we would kind of apply it, but really, really worth exploring and often understanding mental distress in terms of people's kind of powerlessness, in terms of their experiences, and in terms of the world that they're kind of living in. So really worth kind of looking at them. Okay. And words matter. This is kind of a short letter by Keir Harding. And just to kind of read this out. So the voice of those that want the term personality disorder eradicated is loud, and the voice of those insisting that their own personalities are disordered is inaudible. So I think we really need to think critically about the diagnosis and the impact that that has on kind of people's identity and their sense of selves. Now, like, people might appreciate the diagnosis, particularly as it gets access to treatment, and that's absolutely kind of fair enough. Sometimes the diagnosis might give people hope in terms of, right, okay, people know what I've got, or I've got this diagnosis, therefore there must be treatment attached. There's other people that have got this diagnosis. It can bring people together in a lot of ways. I think is that it should be up to the individual to decide that in a way. And if they don't like it, and if they don't feel that having a label of being disordered is helpful for them, or it might actually be harmful for them in terms of kind of self-stigmatization, then should it be imposed on them? And I've certainly done work with people where I might have written letters on their behalf to their GP and stuff like that. And we use the diagnosis because we sort of operate in a system that uses the medical model, but then actually having to do a bit of work with them around kind of, look, I know I wrote that letter and I used that sort of diagnosis, BPD, EUPD. How did you kind of feel about that? And people saying, I actually hate the diagnosis. I'm ashamed of it in a way. I don't tell people I've got that diagnosis because I'm worried what they'll think of me. And that's not particularly useful in that sense. It's got a huge impact on people's identity. Our insistence on labeling people as disordered is a poor start to any therapeutic relationship. And there's certainly a strong argument that if you are purely diagnosis focused, then you are non-mentalizing because you're not looking beyond behavior, you're not looking beyond symptoms. And it's a label that leads to closed minds rather than open arms. And I think certainly when we talk about stigma in a minute, hopefully that will become clear. Okay, so how healthcare helps and how it harms. And I think it's important to remember that we have the potential to do both despite our intentions. So treatments, personality disorders were historically viewed as untreatable. Don't think they were untreatable, we just didn't have the right treatments. Thankfully, that's not now the case, although there is still a lot of therapeutic pessimism around the diagnosis, which is not necessarily helpful for anyone. Pharmacology. Now, medication is often used for people diagnosed with BPD. Might manage symptoms, but it's not an effective treatment for the entire distress or disorder, as it might be kind of labeled. There's no one medication licensed for BPD. You'll often see people medicated for a variety of different symptoms. Obviously, BPD comorbid with a variety of different different mental health diagnoses, and people have different experiences. And if medication helps people for different things, then that's kind of fair enough. But it can lead to kind of polypharmacy, which is not necessarily helpful. Medication can be sort of teleological, so a quick fix with limited benefit. Sometimes because people feel like, oh, I just need something, please give me something that will give them hope. And sometimes that's us as kind of practitioners. We don't know what else to do, so we'll prescribe something, we'll do something instead of kind of trying to understand that mental state. And I think the issue that I sometimes have with medication is that just that it's oversold. I think if medication helps people as individuals, absolutely, I think it should be individual choice. If people think it helps them, go for it. But I think we should know that it's more of a kind of psychiatric anesthetic. So an antidepressant is not going to take away your depression. Antipsychotic is not going to take away your psychosis. What it's going to do is going to provide some kind of relief of that. Yeah, it's not going to be a cure. And I think that antidepressant, kind of psychotic can sometimes be a bit of an oversell of it. And Eric Mazel writes around that in The Future of Mental Health, that things should be labelled as psychiatric anesthetics rather than cures. So some of the psychological therapies we've got there, DBT, MBT are the best evidence is for them, but there's a variety of different things there. And certainly Peter Fonagy would say that there's a variety of different therapies, all show that they have benefit. So what we should be doing is actually looking for the common factors around that. And often the common factors can be understood in terms of the therapeutic relationship, in terms of there can be difficulties trusting other people. So within a therapeutic relationship, we should be helping people learn how to trust again, helping people around that kind of way of seeing the world. And certainly for us, always start with empathy, always start by taking that person's perspective, valuing them as a human being and trying to understand them in the context of their life experiences. There's all the kind of evidence for the psychological therapies, but the difficulty is that people with the diagnosis often present with repeated crises and frequently access kind of generalists, so just not specialists in primary and secondary kind of care services. And that'll be kind of a variety of kind of professionals across environments, accident, emergency, acute mental health, inpatient environments, GPs. So they'll present across a lot of areas. And most people with a diagnosis will improve over time. I think it's important to have that hope, but there's things that we can do to help in the meantime, and there's things that we can do that actually don't help. And really important with you think about that. Stigma. So BPD carries significant stigma, and if you just take a moment to think to yourself, what do you associate with BPD? There certainly, when I worked in an acute mental health inpatient unit, there was an association with people being difficult, misunderstandings of behaviour that labelled people as attention-seeking, just behaviour. All that stuff was kind of captured around the diagnosis, and I remember there was kind of sort of early mornings. You go in at 7 in the morning, and someone will do a handover and say, right, okay, somebody was admitted at kind of 3 in the morning, took an overdose, they've got a diagnosis of BPD, and the whole room just sighs like, oh. And that's a person written off before you've even met them. And there's been some research done that says that people with a diagnosis have a red light flashing when they enter these environments. People have such an idea of what they're going to be like. And we do ourselves and people a disservice when we don't mentalise and give them a chance on their own merit. So the stigma linked to BPD, not being seen as a real mental illness, being seen as untreatable. Staff feelings of powerlessness. I think it's really important that we mentalise, why are we feeling the way we're feeling? I think staff are justified in feeling really kind of frustrated at times, but then we have to think, what is that frustration about? And for me, it was sometimes I didn't know what to do. And I wish I could go back in time, because now I've got a much better understanding of what was going on than I did. Preconceptions that people with a diagnosis are manipulative. And I think you can reframe manipulation as just trying to have your needs met. Sometimes not in very kind of, very, I don't know, articulate ways. When we're talking about attachment being an adaptive process, people will do what has worked for them in the past, and that might not carry forward well in new relationships that well. And a poor level of knowledge and understanding of the diagnosis and symptoms. And I really think anyone that's working with anyone with this diagnosis should have a good understanding of attachment and trauma in particular. And like I say, I wish I could go back in time and understand and deliver care in a way that's better than what I did. Now, the self-fulfilling prophecy is a really important one, just to kind of give you an example of this. So in 1968, there was a study where a group of psychologists went into a school and said to the teachers, right, this group of people over here, these teachers, these students as represented by Jesus here, they're really gifted, right? These guys are going places. Now, these guys represented by Zoidberg, unfortunately, you know, I mean, they're trying, but they're just not as gifted as these guys. Now, there was no statistical variation between the groups of students at the start of the year, but at the end of the year, the group that were called gifted actually did better than the guys that weren't called gifted. And the reason for that wasn't because these guys were more gifted, it's that because the teachers had belief in them, they invested more time in them, they invested more hope in them, and as a result, there were better outcomes. So it's really important that you keep in mind your own attitudes and your own belief and hope in people, because that will have an impact on the outcomes for people. Okay. Iatrogenic harm, which means pain, illness caused by healthcare. Now, people have significant distress and can be a serious risk to themselves, and that can be really, really difficult to work with, okay? So I never want to minimize the genuine distress that staff can feel. It can be really hard, wondering what to do, wanting to help people and feeling like whatever you're doing isn't working, okay? What that can push teams to do is in a defensive psychiatry, where decision-making goes beyond patient-centered morality, moving from doing the right thing and into the territory of being seen to do the right thing. And when I was talking about kind of maybe prescribing loads of medications because we don't know what to do, polypharmacy, that's not necessarily going to be helpful. If we're keeping people in hospital for long periods of time, doesn't seem to be working. People maybe having recurrent crisis in hospital. I understand the need to do that, the feel to like, I feel like I need to do something, so I'll do this. But then if it is detrimental to people, we need to kind of look at our part in that as well. So despite no medication being licensed for BPD, it is associated with polypharmacy, and worked with a lot of people that were diagnosed and had kind of antipsychotics, antidepressants, and mood stabilizers. And you think, what are we doing there with all this kind of medication? We need to sort of sometimes pare that back and start from scratch. What is the purpose of this? People experience a lot of kind of stigma, discrimination, and non-caring care. So think about if you've been in an attachment relationship, potentially with parents, or been bullied at school, whatever, been traumatized. You don't feel like you're worthwhile, you don't feel valued, your needs have not been met. And you go into an environment where people are maybe ignoring you, people are not kind of taking you seriously. And that's a kind of reenactment of early experiences, which can be sort of re-traumatizing. Hospital admissions can be lengthy, been up to, in my experience, 4 years long, and that's 4 years for a kind of crisis admission. And we need to think of the damage that we're doing during that time. And we could argue that the person might be safe in a way because they're alive, but they might be alive but experiencing a social death at the same time. So they're not getting, they don't have outside relationships, they're not having jobs, they're not getting those outside connections. 4 years in hospital, you can become institutionalized. And people with diagnosis can be inadvertently re-traumatized by health services. So the example I gave of, I guess, not having your needs met is one. But if you think people have got significant trauma histories, and they might be in environments where their human rights are removed, where they might be detained and restrained. I remember a really difficult restraint with somebody. While we restrained them, was screaming, "Please don't rape me." And that's a really powerful and horrible example, but we need to really think about what we're doing to people and the impacts that it can have for them, and try and not re-traumatize people, and at the very least kind of talk through these things with them afterwards. Okay. So trauma-informed care, I mean, I've been alluding to this as we kind of go through, so I can certainly rattle through this, but looking through a trauma lens, mentalizing, and remembering, trying to keep in mind what has happened to people rather than just what you're seeing on the surface. Sweeney writes that behaviour might appear extreme or even abnormal when a history of past adverse events is not taken into account. So remembering the subjectivity of people's triggers, people might have significant kind of difficult attachment histories. We need to take that into account to be able to understand people. You cannot understand a person without their context. And people might have understandable difficulties understanding and trusting others. There's some resources here that I'm going to show you from Beacon House that are certainly worth looking at, particularly if you want a deeper understanding of of trauma. So it's moving from traditional language to trauma-informed descriptions. Compassion instead of blame, hope instead of hopelessness, and connection rather than disconnection. And I want you to just pause for here for a minute and have a look at this. So I would imagine that people might recognize some of these things that have been some ways of describing people's behaviors, describing people as attention seeking, and we can maybe reframe that as attachment seeking. People are feeling vulnerable and they're wanting to connect. People are not engaging, but maybe they just don't feel safe yet. We really need to be thinking carefully about what's going on for people. Okay. Now, this is a paper that I wrote that came out this year, and I spent 3 years on it, so I'm really keen to plug it at every opportunity I get. It's open access, so please can I go and read it. It's got some of the ideas that I've been talking about here. But most of us, particularly if we're not working in specialist environments, will work with people with a diagnosis when they're in crisis, when they feel overwhelmed. But people have unique and subjective experiences of crisis. And as such, the diagnosis is not necessarily helpful in terms of crisis care. So we need to think about actually what are people's needs rather than what is their diagnosis. So hugely different group of people with the same diagnosis. So as you can imagine, different crisis experiences. So it's better to ask what's going on for you, how can we help, rather than what is your diagnosis. Crisis care often focuses on behaviour rather than the underlying distress. We'll often respond to suicidality and self-harm, but not necessarily have that mentalising conversation that says, right, you self-harmed, I'm just wondering what was going on for you before that. What sort of led to this feeling, this thought or feeling that led to the self-harm? Where do the suicidal thoughts come from? So we need to understand that. And our care delivery, which has been described as poor at times, can be helpful or harmful, and it's often influenced by human factors. And what I'm going to do now is show you a brief a concept map from that paper that you can look at. You just pause for a second and have a good look at that, and then I'll talk through a couple of bits of it. So I'm not going to go through everything, but just to focus a minute on the factors that influence professional interventions. So the quality of care that we deliver depends on some of these things. So we've got professional education. So how much do you know about what BPD is, or maybe more importantly, the message of this, what BPD is not? And it's not a person that's necessarily disordered. It's a person that makes sense in their life context. The resources that you've got to actually be able to work effectively with people. Uncertainty regarding responsibility. It's often a focus on, people should take responsibility for their own problems, that kind of stuff. But then, at the same vein, we often remove people's responsibility. So there's a bit of a contradiction there. We want people to take responsibility, but then we detain them, we restrain them at times. So we need to think about that. Team conflict. It's a difficult. The distress is difficult to work with sometimes because it's anxiety provoking. We don't want people to die. It's difficult to see people in distress and feel like you can't help them. That can lead to difficulties mentalizing, and we stop mentalizing the patients that we're working with, and we stop mentalizing each other as well. So you need to think about your own distress and access to clinical supervision. And anyone working with people diagnosed with BPD, we need to be having clinical supervision. We need to be sitting down and thinking about our thoughts and feelings and our understandings of what's going on. Because if we're not encouraged to sit down and think and process it, we can be non-mentalizing all the time. And we are behavior focused and not thinking about what's beneath the surface. And just the two at the end there, so the positive and negative experiences, almost direct alternate mirrors of each other. So what's positive for people? Having access to care, being able to get contact with professionals, being person focused and focusing on the kind of underlying distress rather than just the behavior. And Peter Fonagy makes a good point on a YouTube video that I watched with him, thinking about why do therapists become less effective the longer they work. And he says it might be due to kind of working with people in a kind of diagnostic category where you see, oh, I've worked with loads of folk with BPD or diagnosed with BPD. So when you see the diagnosis, what you think is, that's just another one of them, just another one of them, just another one of them. And you miss a person's unique humanity. And as a result, you're not necessarily, you're certainly not person-centered. And if you're not person-centered, you can't necessarily be effective. And the other things that we need is joint decision-making, which we don't always have, and hope, as I've already discussed. So that's been a real quick rattle through. I've probably been slightly longer than I maybe thought I would, but I think it's important. I don't think there's anything I could have kind of neglected to say there. I think it's all really important stuff. So some takeaway messages for you. BPD is controversial and the label can be damaging. Okay, now some people might have the BPD diagnosis and might be fine with it, and that's absolutely good. You know what I mean? If people find comfort in that, I think we need to look at people as individuals and think, if that works for you, that's fine. But if it doesn't, then we need to think about the harm that we're doing to people, particularly around kind of self-stigma. The people's behavior often makes sense if we understand their stories and contexts. Okay, so keeping in mind that trauma lens and keeping that mentalizing focus. Yeah, so what's behind behavior? What's going on behind that? Nurses and other professionals need to mentalize. Okay, and you think about that in terms of if you're on an airplane and the oxygen mask comes down because it's going to crash, you put your own oxygen mask on first rather than put on for someone else first. I stole that from Peter Fonagy. Thanks very much, Peter. I said that like I know him. I don't know him, but he's certainly someone that I admire. So you mentalize first before you mentalize others. Okay, you have to have that self-awareness. What am I thinking? What am I feeling? Where's that coming from? Do that first and then wonder what's going on for someone else. Understand that it's never just behavior. Okay, if you say it's just behavior, or if you're focusing on just a diagnosis without seeing the person, you're not mentalizing. Behavior is influenced by mental states, and behavior is full of meaning. And patients should not be seen as labels, but as people with stories. Care should move beyond that behavior management to empathy, encouraging, mentalizing, and understanding underlying distress. So if we might see people present with suicidality and self-harm, absolutely, we respond to that in terms of keeping people physically safe. But we need to think about that emotional kind of safety, that emotional containment as well. How can we really connect with people, help them understand themselves and help them understand other people? And healthcare can help and healthcare can harm. And I know it might not be people's intentions to do that, but I think we need to be honest at times about when we are doing that. And that was a difficult journey for me, I think, over a number of years, recognizing not only the good that I'd done, but the harm that I'd done to people as well. And I've certainly got ghosts where I think, if only I'd known everything that I know now about people with that diagnosis, what that diagnosis is, what it's not, trauma attachment, I think I would have been a better nurse. And so hopefully, as a result of that, this has been useful for you in some way. Like I say, I hope it's been engaging, because I've been in a room talking to myself. I've been talking at 100 miles an hour. I've scratched on the surface of some concepts, and you've probably got a lot more questions, but hopefully this gives you a kind of some direction in terms of where to go next, in terms of kind of things that you want to kind of learn about. So thanks very much for inviting me to do this. I never miss an opportunity if I am invited, because I think it's really important that people know more about the diagnosis and the people that have that label and the experiences that they have, because I think it's people that are often misunderstood and often let down by healthcare services. So I do miss that human connection, because I've got no idea whether this has went well or whether it's not. So please feel free to kind of email me or find me on Twitter. Let me know what you thought, any kind of questions. And feel free to email me if you're wanting any references or anything like that. And thanks for having me, and all the best for the rest of 2020 for you. Thank you.